Hello, everyone. Welcome. So glad you could join us today. My name is Preeti George. I'm the project director for SAMHSA's National Training and Technical Assistance Center for Early Serious Mental Illness, also known as the ESMI TTA Center. We're so pleased to welcome you to our webinar on developmentally informed shared decision making. So we're going to get started. I think we have quite a few people on the line already. So we'll just go through some housekeeping slides as people are sort of logging in right now. So we'll go through just quickly some of our disclaimer slides. So the views, opinions, and content that are expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, or CMHS, the Substance Abuse and Mental Health Services Administration, or SAMHSA, or the U.S. Department of Health and Human Services, or HHS. Okay, so just as you're logging in, we have a few housekeeping notes just before we get started. So just so that you all know, this presentation is being recorded. During the presentation, you're welcome to submit any questions that you have through the Q&A feature that is down at the bottom of your screen. At least it's at the bottom of mine. So feel free to submit any questions, and we'll have a Q&A session to address some of those. We will be making these presentation slides available after the webinar is over. We'll be sending those through email. And also, if you notice, we have a number of individuals who have ESMI TTA Center next to their names on the Zoom. So feel free to reach out to them if you have any questions or you need any assistance throughout the webinar. Okay, so for our session today, I'm going to start by introducing our speakers who will lead us through presentations, and we'll also have discussion with program participants who will provide a first-person example of using shared decision-making to help address their needs. So after we go through the presentations and the discussion, we will end with a question and answer session and then closing remarks at the end. Okay, so for our webinar, these are our learning objectives. We will be working through material that will help describe best practices for providers on how to use shared decision-making with younger clients. We will be discussing ways and the roles of family education and involvement in shared decision-making, and we'll talk through and identify shared decision-making tools for client engagement and skill building. So this is a slide to talk about this term that you may hear during the presentation. The term ESMI stands for Early Serious Mental Illness. So this is a working definition that is used by SAMHSA, which is currently on the screen. But just as a quick sort of summary, essentially the term ESMI is a term that's used by SAMHSA to refer to the initial period of onset, so the early stages of onset of diagnosable mental, behavioral, or emotional disorders that have an impact on people's interpersonal, academic, or occupational functioning. So just so you understand that that is the term that may be used as we discuss some of these topics, but the initial period of onset, the early stages of it, is sort of the primary time period when ESMI refers. Okay, so now I'm going to introduce you to our speakers, and we're so pleased to introduce them to you today. Dr. Jane Elberg is one of our speakers. She completed her undergraduate studies at Cornell University, and she earned her medical degree from the University of Buffalo, where she also completed general psychiatry residency and a fellowship training in child and adolescent psychiatry. She's the program director of On Track New York at Erie County Medical Center, and she supports young adults experiencing early psychosis there. We also have Erica Caballero. She was born and raised in Buffalo, New York, and she's a licensed clinical social worker with a master's degree in social work from the State University of New York at Buffalo. She has worked at the Erie County Medical Center for over a decade, and she's worked first as an inpatient social worker, and now she's a team leader for the On Track program there, where she supports young adults who are experiencing first episode psychosis. So I'm so pleased to turn things over to Dr. Elberg. Thank you so much.
Thank you. So I'm really delighted to be here and to talk a little bit about how we think about shared decision making with adolescents and young adults. And in working with young adults with ESMI, it is usually their very first time interacting with definitely the mental health system and sometimes just the healthcare system in general. And we feel very strongly in our first episode psychosis program, shared decision making is a core value of the program. We can advance the slide. So I just wanted to start off with just a definition of shared decision making. So shared decision making is a person-centered approach. And it's really a collaborative process between service providers or professionals who are working together with individuals receiving services. So in our case, these are young adults, adolescents and young adults, and their support persons who are usually family members. It could be anybody who's supporting that particular individual. And why we're talking about this is that, as a healthcare provider, a lot of times we want to be able to engage with our participants and their families. And we want to get them involved in the process. And using shared decision making really lays that foundation for partnership and really increases and improves engagement. For the young person who's going through a chronic condition, maybe that's their very first interaction with the healthcare system. And in our program, this happens to be their first episode of psychosis. They really want to be respected and they want to have a voice in the process. And so shared decision making helps them feel more autonomous and have a feeling of satisfaction, feeling respected as like an active decision maker in the process. For family members who are trying to support a young person going through a chronic illness, especially with early serious mental illness, this can be really frustrating and scary situation where that family person might not feel as involved in the decision making. They may not know about what the young person is going through. And shared decision making includes them in the process, gives them a voice at the table, while also collaborating and facilitating ways that they can support that young adult in productive ways. So through shared decision making, providers will use a very collaborative process to help individuals and families explore those treatment options, develop plans that really reflect their preferences and values, and make choices and informed decisions about their treatment that are right for them. It really offers this framework so that you have a vision of recovery and supporting the individual's goals, which is the most important thing. If you can advance the slide. Just a few things about shared decision making. There's quite a lot of research and data on this. It was originally created as a means for talking with people about medication treatment options. And as you'll see later on, I will actually demonstrate how we use this specifically for medication management and how I've used this with participants. Shared decision making can be really extended, and it is extended to all decisions, including housing moves, academics, whether to re-engage in hobbies, meeting new friends, relationships. And we'll hear from one of our participants and his mom about that process and how they used shared decision making to talk about school choice. Studies do show that shared decision making can lead to increased levels of satisfaction, quality of life, and support around treatments, and feeling like you're respected as an active decision maker, an agent of change in their own lives. I think one of the criticisms or one of the feedback sometimes we get from young adults with some of their healthcare experiences is that they sometimes don't feel like they're part of the conversation in specific decisions. And shared decision making is an active and collaborative process where young adults do have a voice, and they're going to be confident that they're going to be heard, and that their decision is going to be respected. If you can advance the slides. Thank you. It is especially important to think about how we're going to do this with youth. And so most young adults that are experiencing a mental health condition, especially early on in their mental health experience, some of them might be minors. And so they don't actually make those decisions. And so we always recommend that, you kind of know about the state you're in and the consent laws. But we would say that even with a minor, and as they're navigating this, we would want to hear what the minor has to say. So even if the legal decision maker might be a parent, in adolescents and young adults, we want to be hearing from the young adult and listening to their preference. And there's some nuance in how to help families and young adults navigate this process, even if they are under the age of consent. It's really important to create a positive first experience for these individuals related to healthcare decisions. This may set the stage for future engagement with healthcare and mental health system overall. And we actually have a lot of research in knowing that transitionally age youth, which are adolescents and young adults between the ages of 16 to 25, struggle the most with healthcare transitions as they move from the child system of care to the adult system of care. Their engagement with health overall, and shared decision making is an opportunity to engage youth in those decisions early on and keep them engaged throughout the process by making them feel like they're part of the decision making process, and that their choices are going to be respected and they're going to be heard. So especially with youth, it's really going to help them feel empowered, especially at a time where they might feel like they're not in charge of what's happening because they're not in control of what their experience that they're going through. And it's definitely more complicated with youth because you also have families that they're living in and their loved ones, and we want them to have a positive experience and having those healthcare decisions. And so we want to employ SDM pretty early in for these individuals. And as we think about youth, the developmental tasks of an adolescent and a young adult is to transition effectively to becoming an adult and making those decisions on their own. And so shared decision making really empowers them to start that process early and helps families how to navigate that process and support that young adult by shifting autonomy over time and that responsibility of decision making to the youth as they grow, and giving them opportunities to develop these decision-making skills, like knowing what questions to ask, knowing how to advocate for themselves. And this can be anxiety provoking for families as they're doing this, because at a time when a young adult might be in crisis or might be having some challenges, to shift that autonomy to the young adult might bring up some anxiety for families or for their support persons. And that's where the healthcare provider can help manage that and facilitate discussion, collaborative discussion, productive discussion, and model how that can occur. We can shift the next slide. In terms of thinking about some developmental issues that may come up for young adults. So like I was saying, that a major thing that occurs in this adolescent to young adult age period of 14, 16 to 25 is that young adults are trying to figure out who they are. that's their time to develop their identity, figure out what are their values. And when you're diagnosed with a chronic illness or receiving treatment, that can really impact your sense of self and your identity development. So at this very critical time, they are interacting with the mental health system and are questioning, who am I? And so that can be really disruptive to their development. And so what we want to do is use shared decision making to help them stay on their developmental trajectory. And so some things that we have to keep in mind is that we want to definitely be using non-stigmatizing language to separate diagnosis from identity, because this is one of the challenges that young adults might be struggling with. What does this mean for me? Who was I before this occurred? Who am I after this occurred? How does this affect me? Another thing to keep in mind as a normal developmental experience is that adolescents and young adults shift their focus from relying on their families to relying on their peers and becoming more peer focused as opposed to parent focused. And so for that reason, we have to think about like their levels of disclosure. What are their preferred levels of disclosure? What might they want to tell their immediate family, extended family, and their peers as well? And because they rely more on their peers, keeping in mind that involving a peer support specialist can be incredibly profound and powerful for a young adult to feel supported, to feel heard, to feel understood by someone else who might understand what it's like for them going through this experience. A lot of our programs have peer support. So our on-track programs for first episode psychosis, for example, involve having a peer specialist on the team to support young adults as they're going through their experiences in their recovery. And then the third piece that we have to remember is that, again, there's a shift in becoming more independent, more autonomous as young adults and in teens are moving towards the adult role, successful transition to the adult role. And so it's really normal for adolescents and young adults to want to become more autonomous and independent from their parents and caregivers at a time when they might be perceived to be struggling more, and those parents and caregivers might be more anxious to facilitate that autonomy. And this really should be identified as we're doing shared decision making and supported as part of very normal development. And what we can do as healthcare providers is provide some scaffolding and some support for both the teen and the parent as they're going through it, so that everyone feels comfortable in being able to shift some more of that autonomy to the young adult. And that is actually going to help them stay on their developmental trajectory and be successful in their transition to the adult role. And so shared decision making will really empower adolescents to participate in their healthcare decisions and will support really a healthy shift from childhood to adulthood. If you can turn the slide. So in terms of how do we do this, we want to learn, first of all, want to get to know our participants and their families. We want to know who they are, what's important to them, what are their goals, what are their values. And everyone is different and they might value different things. And what we want to do is we want to explicitly invite participants in shared decision making. We want to say that this is what we're going to do and that they're going to be part of the process. We're going to present options and information based on benefits and risks and get their take on what they think about those options. We're going to facilitate this deliberation and decision making, and we're going to come up with a shared blueprint of how to move forward. Can advance the slide. And that brings me to how do we do decision making? We have this 3-talk model of shared decision making. So the first part is called team talk. And so in team talk, the healthcare provider will articulate that there is a choice to be made and will collaborate with the young adult and the identified support person to participate in the decision-making process. So examples of this could be, we have a decision let's work together as a team to think about what options might work best for you. And maybe if it's a minor, you could say something like, you have an equal seat at the table and your voice matters in this decision, as using active examples. And the next part of after team talk, we have options talk. And in options talk, we go into more details where the provider might explore what the options are and will invite the individual and the family support person to discuss the risks and benefits of each option, including doing nothing. And after each option, you can offer the opportunity to ask questions before proceeding to the second option or the third option, depending on what's going on. And when you're describing those options, definitely depending on the age and development of the participant, you want to be using, developmentally appropriate language and taking into consideration their cognitive stage and their age and talking about it. So saying something like, let's work together to explore the options, including advantages and disadvantages, and collaboratively doing this together. And then after that, we have decision talk. And that's when the healthcare provider or the professional and the individual and the support person will discuss the options in a collaborative manner and make that decision based upon the individual's preferences and goals. So here is something like, based on what we discussed, what do you think matters most to you regarding this decision? Going back to your goals and what we've discussed, what do you think, where are you thinking about what option might be best for you at this time? And in this process, we must acknowledge sometimes the family support person and the participant might not agree on the decision. And that's where the healthcare provider or professional can come together and highlight and reflect on where we're at and try to find some common ground so that a decision can be made and then all voices are heard. It's very important here to think about legal implications because of, if you're working with a minor, the consent, it might be from the parent or from a family member. It's really important to honor personal choice for both the loved ones and the minors. And also keeping in mind, in terms of who's participating in the team talk, that the legal decision maker might be a parent, but sometimes in some families, the decision is made by other folks, like maybe it's the grandparents, depending on the cultural consideration, cultural norms in the family. So there are lots of factors to consider. It's really important to use age-appropriate language, maybe using visual aids to kind of highlight the decision. And I'll give you an example of that in a minute. Being able to answer questions and navigate intergenerational conflict as well, if it comes up. We'll move on to the next slide. And then here is an example of shared decision-making that we've done. So you can move the slide. So this is an 18-year-old high school senior who was discharged from a hospital after experiencing first episode psychosis, and was hospitalized, discharged with the schizophreniform disorder diagnosis, and was prescribed an antipsychotic or propofol at 30 milligrams daily. And when she came in, she was having a lot of restlessness, akathisia, and was having some side effects. So she had some rigidity on her exam. She talked about how she hates the medication and really wants to stop it. Her parents were terrified because of the challenges she was having before. And even though she's 18, they've been making a lot of decisions for her. And there was a lot of conflict at home, and really didn't want her to stop the medication, want her to continue the medication. She was really anxious about returning to school and felt like a lot of pressure to just get back into things the way they were, but she was having a lot of challenges in school because of focus and concentration. And so we worked together, if you can advance the slides. and talked about options, which were lots of opportunities for shared decision-making regarding medications, school, and also even the family conflict and how to move forward. I'll tackle the medication piece just to demonstrate. If you can advance the slide. So we thought about what's important to Leah, our participant, and her parents. What are their goals for treatment? And so we engaged in team talk, which we said there are options for treatment. You know, we can keep things the same, we can lower things, we can raise the dose, which wouldn't make sense. We could switch, we can try a different form of our medication, or we can do nothing. Next slide. And then for options talk, we went into details here and talked about pros and cons. And here we talked about, you know, if we stop the medication, your side effects might go away. But, you know, 80% of folks who go off their meds might have a recurrence. But if they come back, you know, we could restart the medication and maybe you'll feel better. Sometimes symptoms can linger. Then we got into more detail about switching. What would that look like? And then discussed other options like lowering the dose. And so for each one, we would outline the pros and cons of doing this or that. If you can advance the slide. And for decision talk, once we got there, we were able to identify that, like, it's important for us to think together, identifying each option and for both Leah and for her parents, what they thought about each decision. And even though she was an adult, technically she was 18, she really weighed her parents' opinion and they were part of the decision-making process. And what was really important for me to say is that I can share my recommendation, but I'm going to support you and your parents in the decision so that it's explicitly said that we're here to do this together and that we will respect the choices of our participants and their families. You can advance the slide. And what really helped is using something called the decisional balance worksheet, where for each option, you could do option 1, 2, 3, 4, outlining the pros and cons. And sometimes seeing it on paper is really helpful, if you can advance the slides. So for example, continuing the medication is option 1. What might be the pros? So, you know, they identified staying out of the hospital, preventing those symptoms from coming back, and also reducing conflict with parents was actually a reason to stay on the medication for Leah. For options 2 and 3, in terms of changing or reducing medication, you know, she might feel less tired or less restless. And then continuing the medication, the cons of that would to continue to feel restless, and we're reminded every time she took that medicine, a reminder of being in the hospital, and she really hated it. And for reducing or changing the dose, they thought that the cons of that would be they would cause family conflict because the parents didn't want her to change, and that symptoms might come back if she changed or reduced the dose. Next slide. And so what we ended up doing, we used shared decision-making here. And Leah did want the parents to be incorporated into the decision into the decision balance tool. And we decided to slowly decrease the medication, but she also didn't want to take the medication every day. And so the option of switching to an injectable was really appealing to her and reduced a lot of the conflict. And we added another option and treated the restlessness for a few months, and it went away. And she actually did amazingly well and had, you know, was able to return to school. But this sort of started her experience with the healthcare system. It was very intimidating and scaring after being hospitalized, being in a program like ours, and dealing with it was really her first experience with the healthcare system. And she was able to voice her concerns, and her parents were able to voice her concerns, and felt like the team was able to hear them, support them, and come up with a decision that was helpful to everyone, and all parties felt supported. So this is doesn't always go that smoothly. And so we'll hear a little bit more nuance when we hear from our lived experience perspective, but that's just an example of how we might go about doing shared decision-making, at least for the medication piece. If you can advance the slide. And I just wanted to end by going over some just practical tips for shared decision making, that it's really important to set expectations and roles so that we have a foundation of respect. We really actively listen to our participants and we reflect what they're saying so that everyone knows that we're understanding each other and we're hearing what the other person is saying. We want to be able to foster understanding. So we want to prompt each party to share what they're hearing, especially if sometimes, we'll be sitting there and we'll see that the participant or the family member looks uncomfortable. And so we want to be able to check in. Are we understanding each other? Are we hearing each other? Do you feel like we're on the same page here? We want to be able to create a common welcoming environment. We want to meet in a quiet, private setting, low stimulation, and make that environment warm and inviting so that people feel comfortable sharing their feelings and their thoughts. Even things like setting up the chairs, trying to sit together in a circle so we're facing each other. We're on the same level, no, people aren't necessarily standing, so that we can foster equal sharing. We want to make sure that the environment feels safe. So any comfort measures like having tissues and water, offering the participants and their family members so they feel like they'll be safe and supported. We definitely want to be able to accommodate different learning styles. And so some people do better by seeing things written on paper, and some people want to hear the choices presented. And so sometimes using visual aids is really important. If we ever have folks who speak a different language, making sure we have translated material and using an interpreter to be able to facilitate good communication. Another tip is to be able to chunk and check. So again, using developmentally appropriate language, sometimes especially healthcare professionals tend to use more like language that isn't in layman's terms. And so sometimes we think we're being clear, but it's very dry and confusing. And so using language that participants, especially young adults, are going to respond to, that is appropriate for their level of development. And then summarizing what we've covered so far and doing that in small chunks so that we can check whether we're on the same page with them is really helpful for the shared decision-making process. If you can advance the slide. We want to be able to review that we heard the perspectives and that we want to be able to promote respect and mutual understanding. Always want to invite questions and share resources, and to remind folks that there's no bad questions. There's no silly question. All questions are valid and worthwhile for us to hear. And then we want to follow through. So if a decision is made or a participant voices a preference, we want to be able to follow through in a timely manner so that we foster trust, that they know that we're going to follow through on whatever plan we had. And then lastly, we want to be able to set common ground. So focusing on needs, goals, and common ground, especially when conflict arises, because sometimes participants and families might not agree with the healthcare professional, but they also might not agree with each other, and how to help them navigate that conflict in a productive way is a key part of shared decision making. And if you can advance the slide. And that's the big overview of shared decision making, which is a whirlwind, but I want to give us some time to be able to hear from our participant and his mom about what their experience has been with shared decision making. I did want to acknowledge, though, if you can go back, some of folks that I've collaborated on with Dr. Bott, who is the director of the Stanford Children Inspire Clinic, and Dr. Usher from ESA, who's a medical director there. We've collaborated on shared decision making. So I just want to acknowledge their contributions to this talk. And then without much ado, I want to pass the baton over to one of my my team leader in our On Track program, Erica Curo, who's going to introduce our participants, who is generously coming here to share his experience in our program.
Thank you, Dr. Elberg. So again, my name is Erica Cuyero. I am the team lead for On Track New York at Erie County Medical Center. Today I have with me a participant who has been a part of our program, Deshani and Mom Yandisha. They are here to talk about their shared experience in the program and how we utilize shared decision making. I first want to start by saying that shared decision making is done in every aspect of treatment from the beginning to the end. And we're hoping to talk more about that and how that will reflect in some of Deshani's own lived experience. So hi, Deshani.
Hi, Erica.
How you feeling?
Doing great.
That's good. So I wanted to talk to you today, and I wanted you to kind of answer a question related to what was your initial thoughts of shared decision making and how we used it in the program?
Well, my initial thoughts were that I was very open to it, of course, and I just wanted y'all to believe me and I could do whatever I put my mind to.
Mm-hmm. So my question is, was this your first interaction in the healthcare system with shared decision, well, in the healthcare system, and what were some of your expectations and experiences?
Yes, it was my first time. Some of my expectations and my experiences were that experiences. Well, first I would like to say that my experiences
in utilizing shared decision making, is there one that you can recall?
This is a weird question.
Okay.
Did you have any? You didn't have many expectations, probably because it was new for you, as far as in the healthcare setting. But at the same time, you're kind of were still accustomed to you and I making decisions together on a regular, everyday basis.
So you're saying that shared decision making was something that you utilized pretty frequently.
So it's pretty open to from out the gate.
Yeah.
Were you pretty open to it?
At first I wasn't, but
okay, can we talk about that a little bit?
Yeah.
Why weren't you open to it?
I guess it was an ego thing because at first I was like, there's other candidates, but then that were probably better suited, but then I was like deep down that I did need the help.
So part of it was when we talked about admission to the program, you weren't sure if you were open to it.
Mm-hmm.
And that's when you were kind of like, I don't know if I want to do this.
Yeah.
But what helped you make your decision, you think?
You.
Okay.
Yeah, for sure.
Okay.
I felt like I can trust you.
Okay. Was there? Okay. So one of the things that we talked about is pros and cons and benefits of utilizing a program like our program to help you with understanding your experience.
Mm-hmm.
So that's interesting that you talk about that, because I think that the other part is there's been several times we've talked about and utilized shared decision making. Was there ever a time where we try to utilize shared decision making that we all weren't on the same page? Can you talk about that?
Yes. Basically, when I was going back to school, or I wanted to go back to school, the team, they believed in me and stuff, and I believed in myself, the team here.
Mm-hmm, mm-hmm.
But on the other hand, my mom,
Mm-hmm.
She didn't. I felt like, she wasn't ready for me to go back to school, and she felt like I wasn't ready to go back.
Okay. Okay. So, Mom, do you want to talk about that experience for you and your thoughts?
Fear. Still coming to grips with him going back out into outside of our safe space, with his new diagnosis.
Mm-hmm.
And I think maybe a lot of it was projecting, because I wasn't moving and coming progressing and coming to grips with it as quickly as Deshani was.
Mhm.
And there was still that need that felt like I needed to hold on a little while longer. I need to look and see a little while longer. Yeah, I think the big thing was having the trust, letting him go out into the world and just not being as ready as he was.
What do you, but he had to prove that he was.
Oh yeah, big time.
Right?
Big time.
But for you, what intervention helped you when we were utilizing shared decision making? What kind of helped you come to a place where you were unsure, but we still came up to something that we could honor everyone's
I was
choice?
still unsure. I never was sure. I was still unsure, but I knew it was very important to trust him and to not lose his trust. To not push him away. So I kind of just went silent and said, let's just see. But I don't think I ever
you were always kind of waiting for something to happen.
Yeah, I don't know if I ever came. I don't know how long it took. Not long once he was there, but once the grades started rolling in, and once he was out there navigating and handling it and making it to the classes, yeah, it's like, oh.
Was it helpful to have our supportive education specialist?
Yeah. There's no way I would have come to terms with it without, because there were several times when Phil had to jump on the line and kind of get me going, because I was kind of dragging my feet. Well, come on, we gotta get this paperwork in. And I wasn't vocalizing the fact that I don't want him to, but I wasn't prioritizing it. And I didn't, actually, now that I'm remembering, I didn't even realize how serious it was that it was going down so fast. He's like, come on, I'm getting ready to start school. And what you guys were already discussing for quite a while, and saw was confident, and I wasn't seeing a lot of that. So what I thought was a rash decision really wasn't. And so once I relaxed and opened my ears and started listening to more what you and Phil were saying, and it's kind of like, oh, Deshani said that. Oh yeah. Okay. Well, the only thing we can do is give it a try.
Yeah, so even with some apprehension, we had a plan in place. We had a contingency. We were aware of our pros and cons, and then we made a decision. And what was the outcome, Deshani? What was the outcome of going to school?
I got my associates.
You got your associate's degree, right? Which I'm so proud of you, by the way. But I think that that's one of those things where we often may have some mistrust, and like you said, for you, it was maybe you feeling like you were getting in the way because you had your own anxious
for sure getting in the way
feelings. However, we still had a plan in place.
Right.
And you had me to talk through some of that.
Yes,
right?
Absolutely. Erica always let it be known that you always let it be known you were here for me as well. And that I can directly call you. And I have. And Deshani was always open to it. I've never made any moves without running it by Deshani first. And it's been beautiful.
Yeah. My question is, what are some advice that you would have for people who are using shared decision making for the first time? What's some advice that you may give them?
I would say definitely lean on others for sure.
What does that kind of look like? Okay.
It's hard, like using your own, like in this situation, of course, it's hard using your own strength and like knowledge. Use other people's knowledge for sure.
It was that, because I know we were talking when Dr. Oberg was presenting, like how you could relate to with the medication piece. Is that where you lean on others? Because we understand that you are experiencing it, but you may not understand all of the parts related to the medication. What was your feelings around utilizing shared decision making when it came to the medication piece?
Getting the best results for myself that I possibly can. Not having the side effects and just trying to find what's best for me.
Was it hard having those conversations related to experiencing side effects?
Hello.
What made it difficult?
Because like the medication would work, but like at the same time, you don't want to have side effects.
Mhm.
But like in trying a new medication, it's not the easiest thing. Well, you can definitely do it.
But you know, you get something you definitely can't do on your own.
Especially
It's our
say it's
medication,
better.
something you've never heard of.
So for mine, because I know we in the beginning of the journey when we were changing medications, there were
Mhm.
some reservations for you. Can you talk about what were some of the reservations?
My main thing was the changes. I always wanted to make sure, you know, you see the TV shows, you see the infomercials, when something is treating something and then you hear the long list of the other things, there was a lot of fear in me with the side effects. And anything he's taking in, I'm gonna look up.
Mhm.
And I don't know, just it's I don't know. There was a lot, and trying to hone in and find the right one, and having to trust when the doctors would say, what perfect for one person isn't perfect for the other, and you know how we kind of had to go in and try things and come back out and see how it goes and try another. It was kind of overwhelming, but it was good to know that we had so many options, and that doing so, like trying different things, was actually a good idea, and was never something we were discouraged from doing.
Yeah. And lastly, do I have time for one more question? How was trust fostered? How do you think trust was fostered with shared decision making? What do you think helped? What do we do to help you guys trust us? Because that's important with shared decision making.
Well, for me, I had none of the information, so you kind of have to. This is what my common sense is telling me. You kind of have to. You don't have the information,
but you couldn't
coming in. You guys were so warm. Yeah, so warm. And when we first sat down with you, Erica, and you said you walked through there, you had one spot left, and you saw Deshani, and you said you saw something in him. And when someone's telling me they see something in my kid, because he's the moon and the stars to me, and when someone's telling me that they actually saw something and took the time with him, you got me. And from the front door all the way through, everyone's warm.
Yeah.
No one's ever said leave the. Now I can go back to when he became a teenager, like, you know, and with your primary care, and you know, once you go to 18 and they say, Mom, get on the other side of that door. And then when you come here, and it's so different when it's okay with you, and then I'm invited back in, kind of like into your life. For a part that was like that felt good.
That you weren't,
because that was tough.
Yeah.
When they transition into adulthood, and then you kind of got to go on the other side of the door when they're at the doctors and things like that. And then to see that whole thing change back around and me be welcomed back in was awesome.
Yeah.
Yeah.
Thank you all so much.
Thank you so much.
Great. Erica, Shani, Kesha, we're so happy that you all shared your experiences, and we have some questions. I thought we could just pose the questions to the group now. We can start our Q&A session, but I wanted to just say thank you so much. It was so wonderful to hear your experiences and to hear how shared decision-making can be used in real life for actual people's experiences and how it helped. So thank you again for sharing all of that. I do have some questions, and anybody who wants to respond, feel free. One of the questions is, do you have strategies for talking to individuals about how to select their support person and how to involve them in the recovery process?
I think for me personally, as a clinician, it's always the open conversation of who has shown up for you. Like, who are some people that, if you understand you may be experiencing a crisis, that you know have the capability of showing up, and also understanding that even if you may identify someone, they may not have that capability, so let's have a contingency plan. So always having that open dialogue, and when offered, getting them into some of the sessions so that they understand what that means to be that support person, and understanding that, especially in our team approaches, just as much as I work with the participant, I work with the family and who they identify, because I understand that there's a time where they will graduate from me, but the support person doesn't go anywhere. So I think that that is one of the strategies. So being clear and transparent of limitations if those may come up.
Yeah, thank you. That's very helpful. This is a question I think what providers may try to understand how best to address. So do you have any advice on how to navigate shared decision-making when you're working with a young adult who does not want their parent involved, but perhaps the parent does want to be involved?
I think that could be pretty tricky. And I do think that this is where shared decision making actually can shine, because it does foster that trust and understanding. And I think over time, it can be a way to help that young adult weigh the pros and cons of that specific decision of involving the parent. So getting them to really think about what benefits could there be gained versus, and then really getting and understanding their values and what are the reasons they don't want that adult, their family member involved. And sometimes when you get to those, then you can unpack them and come up with a plan forward that really makes more sense to that young adult. In my experience, in doing this, most of the time, once we really get into those conversations, we are able to at some point get that young adult to appreciate that maybe there's value, and sometimes there isn't. Sometimes that relationship isn't helpful. So really kind of get that young adult to really figure that out. They might have some worry. Well, my parents don't get it. Like in the example I gave, those parents had sort of an agenda, and some of it had to do with their fears and their understanding of what their young adult was going through. And once we worked together on them understanding what the experience for the young adult was, it actually worked out pretty well. A lot of our programs in First Episode, we actually have an opportunity. So sometimes our participants don't mind if we talk with the families, as long as they're not doing it together sometimes. So it's like, yes, you can, my mom can come to family group, but I don't want her in the sessions, which is okay. And then maybe we can involve that parent in understanding what their person's going through. And that builds understanding. And over time, we can sometimes get there. I don't know if that was too much information for this question, but that's my take on it.
I think it's very helpful. Did anybody else want to respond or say anything to that? Okay. Thank you so much. I think that's a question that comes up a lot, and I think that's very helpful. One of the questions we wanted to know, I think that came through the chat, was how do you use shared decision-making when someone may have limited insight about their symptoms or a diagnosis?
I think similarly to, I feel like the approach, it would be similar to the previous question, is first getting to know that person and understanding what's important to them, what are their values and what are their goals. And sometimes it's not getting them to have better insight necessarily, because if you start off from that point, that's not going to yield much. But it's really like, how does whatever I'm going through get in the way of my goals, and can we find some common ground around that? And so usually that's the first step that I've taken in kind of going around it. So we're not arguing about having symptoms or taking medication, but rather like, well, who are you? What do you value? What's important to you? What do you want to do? What are your goals for life and for your future? I think that tends to yield a lot more conversation and collaboration than like focusing on the illness and symptoms. At least that's kind of how I think about it. And again, with that building of trust and relationship, I think sometimes that will get us on the same page at some point, hopefully.
That's most certainly the key, because there's sometimes, we've been doing this work for a long time, that insight is something that everyone does not always gain. That is always our hope. But trust in your providers and them doing what they say that they have intention to do. And if it's, and then if they are not able to, being very clear about those limitations. But I think the key is the trust piece, and as much education related to what is in our means and what is not in our means, to kind of resolve if there is problems in that relationship, if that makes
It does. I think you all talked about that, how the relationship is so important, and trust was so important, especially for Deshani too, in this situation too. So
this might be a little controversial, but like I'll sometimes not even I've moved away from focusing on insight and even using that type of language, and trying to really just find common ground, because the insight, it sort of even has that sort of pejorative way that like, I have insight, but you don't. And because you're looking at the situation a different way, you must not have insight. You don't agree with my recommendation, so you don't have insight. And so I've moved away from it. Even with, maybe having expertise and really trying to understand the person and where they're coming from to try to see if we can meet them there. So that may be controversial, but that's kind of how I've been doing it.
I think it's helpful to hear that perspective too. I think we have just a few minutes, so thank you all so much for this discussion. It's been so helpful, and it's been spectacular to hear all of your insights about all of these things, and we appreciate that. We just have a few more slides here. Just for all the participants who are watching this webinar, we'd love to hear your feedback on how you thought this session went. So you have an opportunity to share that information if you click on this QR code. We also have the link in the chat, so you can go in and answer a few questions about how the webinar was and provide your feedback to us, which would be fantastic. The next slide is just in case we'll send these slides out to folks so that you have Dr. Elberg's and Erica's email addresses. If you have any questions, feel free to reach out. And then we also have a couple of webinars that are coming up in the month of September. So please feel free to register. We have one on September 3rd about partnering with crisis services and early serious mental illness programs. So you can register there, and the link will be in the chat. We also have another webinar about suicide prevention best practices for individuals at clinical high risk for psychosis or experiencing first episode psychosis on September 10th. And so you will be able to register for that as well. I think the registration link is in the chat. So thank you all so much. We have references, so you'll be able to see those. And if you have any questions, please feel free to reach out to the ESMI TTA Center at the website or the email address below. So thank you again to all of our presenters and for all of you for participating. Take care.